I want to call all the panelists from the last group, Bill, Julie, Rob, Lynn, and Alicia back to the table. And we have
the name.
Yes, good. And we have, there's not a clock in this room, so let's see. Well, I think we have a total 12:30, so ample time for Q&A. I'll call on people that come up to the mics. Really, comments and discussion are just as appropriate as questions.
Oh, thank you. Hi, I'm Sherry Ling from CMS. So I have a question for the panel. It's really important for us to understand the broad perspective of how these different care models are actually gathering evidence. You've answered many of my questions about what are the critical elements of the care model. From our perspective at CMS, I mean, not speaking for the Innovation Center, but one of the requirements and that the authorities are based upon is that we have cost and quality in the model constructs. So knowing what you know about what would be in a model, and understanding that function might be critical outcomes, what would quality look like? And thinking about this from the perspective of, implementing new care and payment models, quality of care, quality measures are a critical part of that. Also emphasizing, though, that as we get towards alternative payment models, there are also opportunities to build in quality and engage clinical practices in reporting quality. Have to do it anyway as part of the merit-based incentive program. And so what could, two different purposes, care models, but also the quality payment program. So what would be some quality aspects that we could think about together?
I'll take the easy one, which I think you couldn't discuss quality without some kind of patient-centered outcome self-report. When we're talking about pain, that the patient's experience has to be a part of that equation.
I'm not sure this speaks exactly to that, but Roger had mentioned earlier what Oregon's doing, and we've got a big PCORI study looking at that naturalistic experiment. And this is a place where they've taken very seriously this evidence. They're trying to do it in a risk stratified way. There's these things are being reimbursed, but we are looking at patient outcomes with this. I would say another piece of it is that we're starting to uncover, though, after a year, is a lot of confusion about who to refer to, what kind of care provisions there are. So I think there's a lot we need to know about, and I'm really speaking about stuff in, everyday clinical care, but we're not characterizing these services real well, and we need to understand them better as part of our research.
I'll just say that I think it seems intuitively obvious. I really echo Julie about patient-centered approach to assessing outcomes. But I also think that it is quite important also to think about the experience of the clinicians in our healthcare systems and the organizations themselves. So whether it's, I think we think about that. Different levels, I guess, of analysis when we think about barriers to delivering maybe quality of care, but I think we should use the same kind of metrics or organizational scheme for thinking about quality as well. Other comments?
Hi, Corey Simon, Duke University. Thank you all for your presentations. One thing that I struggle with is we seem to be we're moving towards looking at more at the traits or the stratified care of high versus low risk based on an overall psychological distress. But then at the same time, I look at, say, Dr. Edwards done some work in this, say, the situational pain catastrophizing scale, where we whittle down more to specific things that aggravate people, and it's not so much the trait, but literally the situation in which they're put into that brings that on. So can you speak a little bit to that and how we kind of deal with that, not so much from a trait perspective, but more so the situation, so integrating not just what they're experiencing, but the situation that they're put in?
I think that one of the things to be worked out is exactly what you're saying, is the specificity of risk factor and the specificity of intervention. And I think some researchers have gone they want to be as broad as possible. So let's just take high risk on a sort of general psychological nature, which on these, if you look at the items on these brief screens, they really include a whole mixed bag of things, where if you're a clinical psychologist, you might want to address each one of those in a really different way. But I think, getting to this issue of kind of trying to implement systems within payer systems. I mean, you can't have a cafeteria plan of 30 different psychological approaches to pain and expect that to really be workable from a payer standpoint. So I think we need to find kind of where the middle road is between some specificity related to the nature of patients' problems, whether it's pain catastrophizing or something else, but also being kind of doable in a payer-based system that we have.
So that's a fantastic question. I'm assuming Steve George here paid you some amount to come up and ask an extremely difficult question to the panel, and if so, well done. I can fairly easily imagine series of steps that the field goes through around risk factors, where some of the initial steps that are in fact being taken now involve broad classification of risk, low, medium, and high, that sort of thing. In a way, we could get away with this for a while, in part because risk factors tend to cluster. So we could all rattle off several dozen well-known and empirically supported risk factors, but they're not independent risk factors. So people who are high in catastrophizing also tend to be high in depression and anxiety and to have socioeconomic risk factors. And these things do tend to clump together. So it's certainly possible, at least as an initial step, to stratify things that way and get, I think, good benefit and bang for the buck by matching certain treatments to particular risk levels. But eventually, we're going to get to the point, and I don't know how long it will take, it'll be a while, but we'll get to the point where if patient X shows up and patient X is a woman who has relatively high levels of catastrophizing and shows evidence of central sensitization and says on a questionnaire that she prefers to receive her non-pharmacologic treatment online so that she doesn't have to come in for regular visits, that's going to lead us to select a particular set of treatments that we know from, or think we know from a number of studies, is associated with pretty good outcomes for that type of patient. And admittedly, it will take us decades to get there. But as I probably have decades left in my research career, I'm quite happy about that.
I'll just mention, when we're talking about risk, we've emphasized kind of psychological and the neurobiological foundations of those psychological factors. Often we say psychosocial, but it's really psychological. I would say the recent MMWR that I highlighted point to social determinants and risk associated with, among all others, poverty. And paying more attention to that bucket is, I think, very important. And I would say, particularly thinking about the interface with the healthcare, we're all interfacing in the healthcare system primarily, I guess. I think the interface with the workplace and employers, because a lot of them kind of point in that direction, I think is also key. Other comments? Wendy.
Hi, Wendy Weber. I'm from the National Center for Complementary and Integrative Health, and I'm going to do a little bit of an infomercial for what Dr. Shurtleff is going to talk about later. But many of you are calling for more research or more opportunity to do studies about how do we actually integrate these types of interventions into healthcare delivery? How do we change healthcare delivery so that it is actually implementing the evidence-based guidelines? There is a notice of intent to publish out right now that we plan to publish an RFA specifically calling for those types of research studies, for studies done within healthcare systems that will test different models to figure out how do you actually change care to better adhere to guidelines, or how do you actually implement these services into healthcare delivery to get around the access problems and barriers that you've all been talking about. And my question for the panel is, I know many of you because you're part of either the Healthcare Systems Research Collaboratory, who's done this work in how do you do research studies with broad healthcare systems, or from our pain management collaboratory working with the VA and DoD. And I'm wondering, first, Lynn, if you might talk about some of the challenges that you faced in sort of how do you do this research and partnering with healthcare systems to really change the way you care for pain patients in that model and in those systems. And for those of you that are about to launch studies or part of that program, sort of what are your anticipated challenges maybe in going in and actually changing the way healthcare is being delivered in the sites that you're working in?
Such an easy question, Wendy. So Wendy's right. We're at the tail end of a big study we did in 3 of the Kaiser regions with patients on chronic opioid therapy that was really designed to bring something that's been done a lot in tertiary care, but bring an interdisciplinary team directly into primary care. And I was delighted when we started that because it was the healthcare system coming to me and saying we really need to do something about the patients we're struggling with the most that are bouncing around our system that kind of belong to everybody and no one, and everybody agreed that this was critically important. And despite that, I think the biggest challenge that I think we had was actually getting patients interested enough and willing enough to consider these kinds of treatments, and having a culture of care that really even when people espouse that they believe in biopsychosocial model, the behavior of our delivery systems is anything but. And I think it goes back to the issue of what's easy and what's accessible, so that what you see continue to happen is that people are referred to for lots of imaging. They're referred for surgical consults. There's a feeling that if I'm being asked to or offered to do something that's enhances self-care, that maybe you're telling me it's all in my head and my pain isn't real. So I think we really need to think about how do we introduce the language of this in a way that practitioners are talking about it in this way, that patients are feeling like they're not getting the booby prize. And I think some of it involves storytelling too. I think that facts are not nearly as compelling as really powerful experiences that people can share. So I think it offers us a lot of directions to move. Well, this is true. But not in the way that they're saying, yeah.
I'll just say a word about the Pain Management Collaboratory. So for those of you who don't know about this, probably Dr. Shurtleff will say this, I don't want to steal his thunder. This is an important partnership between the National Institute of Health and Human Services, the DoD, Department of Defense, and VA, in the conduct of 11 pain-focused, pragmatic clinical trials of non-pharmacologic approaches embedded in VA or military health systems. From my point of view, we're early on. It's really in the planning phases of these projects. I can see already that we have even in the VA, I'll speak about the VA, we have a large integrated health system, but still a challenge in terms of our capacity for conducting this kind of research. Most, but not all, of the trials are to be enacted in primary care settings, which, for anybody in the room who doesn't know this, it's a busy place with a lot going on, a lot of competing demands, and the demands for being involved in research is not necessarily at the top of the list of the organizational leaders, the leaders in the primary care setting, let alone the clinicians or staff in that setting. And so, and when we look at where the studies are being enacted, they're mostly being enacted where there is a general internist primary care provider who's a clinician investigator, who's representing both sides of the fence, as opposed to clinicians who aren't otherwise engaged in the research enterprise. So I think there is an important role for these collaboratories and the broader enterprise to really work on not only patient education, as Lynn has highlighted, and the public messaging, but clinician education and messaging to try to increase the likelihood of clinicians in the trenches being interested and engaged in this kind of research. I think that's going to turn out to be an important challenge. Hopefully we'll learn about some of that through these large collaboratory efforts.
Yeah, I would just add to that I think this is embedded in what you say, but barriers are really, our health systems, whether it's VA, military facilities, civilian, we already, and we've talked about it, we have access issues related to non-pharmacologic pain management. So designing pragmatic trials that are being done in health systems where that exists is very challenging. And then the other challenge, and we're recognizing this quite readily, is when you're experimenting on the delivery of care, and more than one person wants to experiment in a different way on that delivery of care, you immediately start to run into problems in that those competing priorities for research, let alone other care conditions, is a challenge. If I'm tweaking the care process and somebody else at another point of entry in the care process wants to tweak it, we're sort of contaminating each other. And it's very different, at least in my experience, in doing a study where we pull out individual patients and experiment on them. It's a different challenge for me.
Great. Last comment. Len?
Hi, I'm Wen Chen from National Center for Complementary and Integrative Health as well. My question really sort of cut across both panels in the morning. The first talk got me very excited this morning, talking about where if people get exposed to acupuncture or massage or physical therapists first, they have, they're 70 to 90% protected from getting opioid overdose. I said, wow, those may be the first thing people should try. And then in this panel, I heard the talk about the Lancet paper recommending the first line therapy would be CBT and exercises, and which is not exactly what was presented earlier. So my question is, as a patient, what should they do first? And is that a question that we should figure out? And do we have enough evidence to recommend for the patients what they should try first? And if not, how should we go about with that kind of research?
So I think I'm of the thought pattern that there are many different ways for patients to improve. And the most important thing is that they have the opportunity to engage in treatments, and that when they find something that they like, that they'll continue to do that, and that's how they get benefit. I think there are many different ways to improve it. For patients to improve, what we need to do is provide a system that makes it easy for patients to get to that care and makes it easy for providers to refer. I think we've talked a lot about first contact. What I found in my own research and implementation is when I talk to primary care providers, they have a very different thought about where non-pharmacological intervention should be offered than from what I think. And helping them to see that earlier referral is actually better. It may help engage the patient, and supporting that through making that easier, I think, are some things. I think we oftentimes get very caught up in what's exactly the right thing to do. Exactly the right thing to do will differ by patient, and we should make it easy for them to make that choice.
Yeah, I think Alicia's exactly right. And in back pain, we often, or the research that's been done, such as it exists on shared decision making, has generally been pushed to the surgical decision at that end of the spectrum. And it seems to me there's just a tremendous opportunity here on the front end to do exactly what she's talking about in terms of really engaging the patient in understanding what their options are and making a choice that they really feel good about. And I think it would certainly suggest that's going to improve outcomes.
So you're suggesting the patients should just try a variety of things as many as possible until they get something that works? Or I'm just trying to understand.
That's kind of what they do now. I mean, I think what we're suggesting is to help guide a patient through that decision-making process with a better understanding of the options that exist to them and then making those options available.
I would say our little bit of work that we've done on trying to understand patient preferences has not panned out very well. I think people coming to a setting of care have some prior beliefs, but they may be not accurate or valid beliefs, I guess, or their beliefs, so they're valid in that way, but they're misinformed, or they don't really they have prior assumptions about what exercise really is or psychological therapy is, but it's not maybe what we would say. And trying to help people in an efficient, effective way get information that can help them make these determinations, or even from our point of view, help them be better informed so they can engage with us in making shared decisions is a challenge. And it's a measurement challenge, communication challenge. I think there's a lot of work to be done in that space.
So, and I completely agree with what my colleagues are saying here. I think the other thing, and this really needs more research as well, but there's many recommendations coming out about self-management as really being the core, and I think the treatments that help to promote and to encourage people to uptake those kinds of day-to-day lifestyle changes and skills are probably critical, and that there are a number of ways and different modalities that can support that, and things that are more or less available in certain parts of the country, things that are more or less culturally acceptable. So again, harder to study things in that way, but I think there's some opportunity there as well.
Did you? Yeah, Sherry.
Yeah, I have more of a comment, and certainly what would be optimal is that each and every patient finds and is guided towards those interventions that actually work best for people like them, right? So it's about the fit. In thinking about, and it occurs to me in conversation with Ben, from the Medicare perspective, it's really exciting to see that there's so much real-world evidence being collected from the system level that is applicable to the care of Medicare beneficiaries. I do also want to say, though, when it comes to coverage determinations for Medicare, one of the major limitations has been the availability of evidence that it comes from patient samples that are reflective of the Medicare beneficiary population. Reminding you all that, as an example, there's a national non-coverage policy for acupuncture because at that time, the evidence was insufficient, and we're really hoping that that will change. This is a bigger issue than just pain management, though. If you think about those of us who practice, how often we refer a patient who is of Medicare age or is meeting criteria for Medicare by way of disability or end-stage renal disease status, how often we refer those patients to a clinical trial, right? And yet that is an enormous opportunity for us to help develop the evidence that's needed for Medicare coverage purposes too. So I just wanted to say that because many don't realize that constraint stems from the Medicare statute. So knowing that hopefully will help you to think about how do we integrate in our trials and our studies those people who would be Medicare beneficiaries, and we're working very closely with Wendy and the NIH team so that we can consider promising new therapeutics. So I just wanted to say that, and thank you.
David?
So to follow up on the previous question, I'm hearing sort of, David Atkins, VA. Two slightly different themes. One, which I completely understand, is giving patients making sure that patients have choices, giving them a wide range, and finding one that they'll stick with. But I did think I heard in Dr. Edwards' comments that there's a subset of patients for whom cognitive approaches are really important, which they may not naturally gravitate to. And I guess the research question as a research funder is, what kinds of study designs do you envision to sort of test that idea that there is a matching of therapy that we could do better with? And is it just straightforward, a randomized trial, or are there other designs that you might think about to really test the idea that there's a subset who really need a cognitive behavioral approach beyond what they'll get from exercise or yoga or other kinds of interventions?
So that's a terrific question, and I bet some of my colleagues here are more experienced in setting up trials with these sorts of complex designs. But I could envision a study, for example, that used something like cluster randomization to set up different practice patterns. And in one case, it is the equivalent to care selection as usual, where patients wind up with a certain treatment course based on their preferences and what their providers recommend for them. And in another cluster of practices, patients are randomized to something like an initial assessment or phenotyping of risk factors, and then recommendations for treatment are made based on matching particular treatments to particular risk factors. And then you could study in those clusters on aggregate, where do you get the best outcomes? I'm a little bit out of my depth, probably, with those sorts of study designs, but it seems possible to me to set up those sorts of trials, which would answer the question, if you take the extra time and expense, and admittedly it is extra time and expense, to do the assessment and phenotyping, and then take the trouble to set up recommendations that match people to treatments according to those phenotypes, does that get you better short, medium, and long-term outcomes than if you run things as usual? That, as far as I know, that sort of work hasn't been done yet. It may be ongoing now, and that would be absolutely fascinating to me and probably most of the people in this room.
I know of only one study that really tested that directly, which was conducted in Sweden for back pain, and it was people were randomized to be in a group where they got matched to treatments based on their psychological risk factors, and the other half was that you were randomized to just get scrambled assignment of treatments, which was, you can imagine, was a little strange, but that's really the truest test I can see. And that did not show the hypothesized improvements by matching treatments. Although in that study was a study conducted by Stephen Linton, but it was, in this case, the three treatments were all, I think, very similar. They were all psychological treatments. So I think we could try this again, but with sort of a wider spectrum of interventions might be more effective.
Can I also just say, in addition to what you both said, you did a great job, much better than I would. But I would, I guess, step back and say that I don't think this is inconsistent with our current stepped care model, in that this is how we offer pain care in the VA, in that if you do not derive enough benefit from a certain lower intensity step, then you move to a higher intensity step. And so some self-management interventions, particularly if we had technology-based interventions that patients could refer themselves to or that were self-guided, patients could easily enter at that step 1 or even step 0, we could think of it as that. Patients who don't get benefit at that step could then be considered for intensification, and maybe that would mean more formal CBT or in-person treatment.
Ben
Kligler again. Alicia, thank you. That totally set up my comment, which is I think I want to encourage everybody to think a little bit more out of the box than so far we're doing, in that we are mostly talking about things that we do to our patients. we do to them. Somebody does it to them, and we need more study of the things that we do to people. And so this kind of goes back to what Julie was saying. And actually the reason that I think, Bob, you can correct me if I'm wrong, but that initial step in the step care model was not there originally, and it was added. It was added because we're learning that pain management is about people taking charge of their own health. And we are never going to have the capacity in our healthcare system to deliver pain care to everybody in pain. We're never going to have the capacity to do all the research we need to. The only thing we have the capacity to do, sorry to be waxing, is empower people to try to take charge of their own situation. So I want to encourage us to think about research that looks at strategies, population-based strategies, for reaching out to people to take charge of their own pain. And again, not to tout us, but we are trying this in VA because we're trying to move the first step out of the clinical encounter to an encounter that happens with a peer or a health coach or in a group or virtually, like the work Alicia's doing. And I just think we need to blow it up a little bit more. And I would just like to encourage that in the conversation.
Thank you, Ben. I'm needing to cut this off because it is 3 minutes past lunchtime, and you don't want to mess with lunchtime. So if if you wanted to ask the panelists individually, please do. Sorry for that.